So, good afternoon, ladies and gentlemen. My name is Miroslav Solonko, and today I'm honored to be a moderator of this wonderful and special event, which is taking place here in Kiev, in Hilton Hotel. And the name of this event is Defense of the Competency. It's a special format that has been held for the first time here, and we'll tell you a short story how the idea of this event came up. So in Ukraine, as probably you well know, we have a gap in medical education and in dental education as well. So we have a gap between the diploma and between the education that we have in the universities. And from the other side, we have a gap between the education and the practical skills that the doctors can show to their patients and to their employers. And that's why the Professor Zablotsky came with an idea that he wanted to hire one of the best specialists in Ukraine in the fields of maxillofacial surgery, oral surgery, and dental implants, and orthodontic surgery, and he didn't know how to check this knowledge. So the question came up that if we have the Ukrainian doctor who doesn't have a diploma of the international university, so how can we check his knowledge? How can we check his expertise? And how can we check whether this person is qualified for this job and whether this person can be called one of the top specialists in the field? Therefore, we have thought of the idea of making the public, we shouldn't call this examination, it's a public defense of the competency in three fields: in maxillofacial surgery, in orthodontic surgery, and in dental implant field. So today, Ihor Proshchyn, which will be introduced in a while, will present us three cases in those fields. And we are happy to have with us today four international and world-renowned experts in the field. And I will now introduce them to you. So today we are very honored to have in the online connection Dr. Sasha Jovanovic. He is one of the world-leading experts in the fields of implant dentistry and bone augmentation. And he is an associate professor at the Loma Linda University. And he is also an academic chair of the Global Institute for Dental Education in Los Angeles, California. We are also very happy to welcome Dr. István Urban from Budapest, Hungary, who is one of the top clinical experts and clinical researchers in the field of bone augmentation and implant dentistry as well. And he is one of the most prominent speakers in this field. He's also an honorary professor of the Szeged University. And our next expert is Professor Simonas Grybauskas. He is the maxillofacial surgeon, and he is one of the world leading experts in the field of orthodontic surgery, practicing in Vilnius, Lithuania, and also he is an honorary member of a number of professional societies. And also we are honored to have Ukrainian expert, Dr. Ihor Fedirko, and he is here with us in the room, and he is head of the clinics of maxillofacial surgery of the Ministry of Defense of Ukraine. And of course, last but not least, I would like to present to you our today's presenter, Dr. Ihor Proshchyn. He is the graduate of the National Bogomolets Medical University in Kiev, and he is a practicing oral and maxillofacial surgeon in a number of private practices in Kiev. In a couple of cities around Ukraine, and also he's practicing in a military clinical hospital in Kiev, Ukraine. Ihor is an active learner, and he is a participant of numerous international events and postgraduate educational events all over the world, in Europe, in the United States, and in South America. And also I would like to mention that he is a recent graduate of the Global Institute of Dental Education in Los Angeles, California. So please welcome Ihor Proshchyn, and he will present for us three clinical cases, which will be followed by the discussion with the international experts and, of course, with all of you who are present here. So, Ihor, the floor is yours.
Thank you. Thank you, Miroslav, for your nice introduction, but I feel more modest than it feels like in your opinion. So, dear guests, dear experts, I would like to start my presentation with the case number one. This is the case of the male who has no bad habits but has systemic disease like diabetes type 1, some obesity, and his chief complaint was he came to us with his problem. He told me that I lost my tooth yesterday and I would like to have it restored before my birthday, which is 1 week away. So that was the situation in the mouth. In our intraoral findings, you can see it better on the next slide. We have some teeth missing. We have dental alveolar extrusion. We have severe abrasion. We have class 2 malocclusion. We have really deep bite. We have posterior bite collapse and teeth misalignment. So periodontal examination showed severe periodontal disease, severe attachment loss, deep pockets with suppuration and grade 2 mobility. Here is the X-ray of that patient. You see that we really have a lot of teeth, but some of them are doubtful for the further restoration. Our diagnosis is periodontitis stage 4, grade B, partial edentulysm, class 2 malocclusion, and deep bite. So we started our treatment planning. We were supposed to study it with periodontal treatment, extraction of those teeth that are irrational to keep and restore. Temporary rehabilitation should be partial denture. Even on these pictures, we can see that we have to augment bone. Then we have to restore the occlusion, to restore teeth with implants, supported prosthesis. We suppose that we will have a hybrid bridge on the maxilla and implant-supported restorations at mandible. So we extracted those teeth that are hopeless from our point of view. We cannot restore them, and that's how it looks in 2 months post-extraction. You can see the contour, which is really irregular. So the augmentation that we were supposing to have is obvious now. This is the X-ray. You can see here also the irregular contour of both maxilla and mandible, and periodontal reevaluation. We have no pathological pockets, and those teeth have some potential. So, treatment planning. We made diagnostic box-up. We started with mock-up in centric relation. We had to rise vertical dimension for more than 6 millimeters. You can see it on those models. Those are the positions of teeth that influence facial parameters the best way. So we tried to simulate the further surgical procedures. Here you can see the simulation where you can see the superimposition of X-rays, CBCT, and STL from scanning. That's how our prognosis looks like. Those are the teeth that we want to achieve. And so we can check if we can put implants in the most predictable positions from the point of view of further prosthetic rehabilitation. So those are perfect positions from the point of view of prosthodontist, and we can now check the bone. you can see that in frontal area there are some implants that have no chance, no bony support if you would put them today. But it's possible to augment this situation. So the next is mandible, because we have missing teeth on the mandible also. This is the same simulation with superimposed scans on the DICOM file of CBCT, and we could start with the planning. With those teeth, we could check the best positions for implants, and afterwards we could make evaluation and check the splint, the guide we should use for the best solution in further prosthetic work. So this is the design of our guide. You can see the guide at the bottom to the left. This is actual guide we used for the surgery. And we can check the safety. We are totally safe from the nerves. The position of implants are quite parallel. You can see it now. And now we can start our treatment. So we started with maxilla. We opened it. You can see regular contour of the bone. This is the situation for the augmentation. So as we had to use dentures, which are removable, which are mobile. We decided to reinsure ourselves by utilizing the titanium reinforced PTFE membrane by Cytoplast. For augmentation, we used combination of bios and autogenous bone, 50-50 proportion. It was quite difficult to position the membrane due to the size of the site, of the recipient site, and the curvature of the frontal area of mandible. Then we sutured it in double layers, utilizing PTFE sutures from Cytoplast. After, we could go to mandible, where we had our implants placed due to our first surgery. This is, excuse me, I'm a bit nervous. This is the next surgery, which took place after the implant positioning. This is stage 2, combined with connective tissue grafting for soft tissue augmentation. We harvested some connective tissue grafts. We positioned them simultaneously with the second stage. And then this is the X-ray of the situation. You see the pins, you see the membrane, you see the second stage of implants. And after, we decided to open the membrane, to open the bone for vessels from periosteum, to check if we have bone. We decided to have it on the month 7. We were not sure that we will get the bone because of the dentures, because they are risk factor for bone maturation, for bone formation. Unfortunately, my slide has skipped somewhere as it decided. So this is reopening. We reopened the area, and we saw the perfect bone. You can see the vessels, it was firm like a rock. We could hardly take the membrane off. It took us a bit of time to take it away. That's why there is a good life hacks for positioning the membrane to make it easier to take if you have success. The contour is irregular. This is because of that the contour of new formed bone is irregular due to complicated positioning of that membrane. So I will go back to where I was supposed to be with my presentation. Excuse me, it's a bit messy here right now. So now we can go to the final planning of our restoration in the new formed bone. This is the simulation again with the superimposition of our planned prosthesis, of our proposition of a new formed bone. You can see the perfect positions of implants from the point of view of prosthetic rehabilitation. This is the position of implants in the bone. Now you can see that they are absolutely inside the bone. We can't see any threads of implants like we saw before. So now we can go for implant placement. Here you can see the new translucent on this simulation. You can see the new formed bone, and those implants, those 3 frontal implants, they are in totally new formed bone. Maybe a slight attachment to the previous bone which we had at the start of the case. So this is the position of implants, both maxilla and mandible. You can see some abutments on the mandible. And now we can go, the next stage is provisional rehabilitation with implant supported. So we have combined upper prosthesis. You can also see the gingiva, you can see the mucogingival line, and it's obvious that implants are safe. And if we look at this slide, we can see that there is enough keratinized tissues around all the implants. We used multi-unit abutments here to be sure that prosthetic rehabilitation will be the best prognosed. So the next is mandible. Implants, it's provisional mandible. You can also see enough keratinized tissue. You can see not bad contour, I suppose. It's nice. This is the scallop of new formed tissues we gained on our soft tissue augmentation. We can see emergence profiles, which are pretty safe at this point of time. So this how it looks. This is facial pictures. We did not want our patient look too young nor too old. That's why those provisionals look like they have to look for the person of his age. You see him almost happy with his result. It took us, and it took him 2 years. So I'm really grateful for his understanding and his cooperation. It took a lot of efforts for him to give us opportunity to work the way we think is the best option for this case. So this is our team from the Dental Center of Dentin. Prosthodontist, it's Taras Mikhalevich. and the periodontist is Kovalenko Alina. Now I would like to switch to case number 2. Case number 2 is about the patient, which is pretty young. He's sporty, he's fit, he's healthy person, no drugs, no medication. And his chief complaint was a bit strange. He asked us to check if he's healing, if the healing of his mandible fractured is doing well. So that's how he looked. He looked like he had, this is day 11 after the beginning of treatment with this kind of device. This is splinted jaws with Tigerstadt appliances. So we started with checking what do we have inside. This is his X-ray. So we have dislocated mandible multiple fragment fracture. We can see that the body on the left is broken in the mental area. We can see angle left, ramus left, and coronoid process is also broken. This is our diagnosis. And what was our treatment plan? For sure, that kind of rehabilitation he has received before is not efficient enough for this kind of dislocations. So our decision was mini plate osteosynthesis, and we were planning to do it intraorally, but maybe we would need extra facial punch technique. So this is the simulation also. This is his CBCT half a year before the trauma. That's how he looked like. His teeth are not perfect, but then his trauma happened. You see in different colors, different fragments. Right and central are almost on their place, so those could be rehabilitated with that old-fashioned classic approach with splints. But on the left, we have really severe dislocation. And this is, I'll remind you, day 11. And I would like you to pay attention to the thickness of his ramus. They are pretty, those ramuses are pretty thin. Now you can see the appliances that were utilized to heal this fracture, but it appears that it had no chance to happen in his, to help in his case. So we decided to do it our own way. We put the mandible together. We used mini plates with screws to put them together. You see how we managed to put the fragments back together from different angles. We also used two extra screws in the front to put both jaws together just to guide the closing of the mouth. So the muscles would not take part in this movement, not to put too much pressure to the frontal fragment. You see those two frontal mini screws. We used only elastics to hold his mandible at the position to be guided with the maxilla. Now you have superimposition of his previous CBCT before trauma. It's obvious that the left side fits perfect the most complicated part. We managed to put it back together as we had before the fracture. But we can also see some deviation on the condyles. I think that on that kind of situation, I'll remind you that we have day 11 after the trauma, so the bone started resorbing and it does not feel that precise as at the beginning, as in first few days. So this is how it looks, and the panoramic X-ray. You can see the plates. We used one bicortical screw.
It's just a matter of setting. I mean,
Excuse me. We can see bicortical screw here to position the coronoid process, because there was not enough space for two plates. And we also can see one complication of our treatment. We put one screw inside the canal, inside the mandibular canal, and the patient had numbness, but now his sensitivity is restoring because the screw is positioned on the upper part of the canal. So I hope it will, the sensitivity will restore, and we did not rupture the nerve itself. I had chance to finish this case only with the help of surgeons. This kind of surgeries, it's impossible to have them only with assistant. You need two surgeons at the surgery, and Ivan Pavlyuk from military hospital helped me. He is now in the room. Thank you, Ivan. And good anesthesiologist, because this patient, he spent his night at home. He did not stay in the hospital for a minute. He woke up. We managed to do it under sedation. We did not use narcosis. We did not put him on artificial breathing machine. So it was the lightest option for him. Actually, the second day, he promised me that he will go outside the city to take care of himself, to read some books or something, or do something safe. But he came with his suit, so he was working. And this is kind of compliment for me, but that was a risky point, because they feel in that way, if you feel gentle, if you behave gentle, they feel too free to live their lives like they used to. So now, case number 3. Case number 3. Meet Yulia. She is really friendly. She let us have all the pictures we had, not unlike those patients that we had before. They are kind of public people, and they asked not to use any of their pictures. But Yulia, she is really nice person. She is young. She has no bad habits, no disease, and her chief complaint was my teeth are sensitive to cold and sore. This is how she looked like. This is her facial profile. But actually, this is Yulia, because she is often always smiling. She's happy, really active young person. Intraorally. What can we see intraorally? We can see her teeth. We can see the reason of her hypersensitive teeth. You can see it on the screen, yes? We can see some recessions on premolar group of upper teeth. This is the X-ray, cephalometric analysis. and the diagnosis. She has skeletal class 3 trend to mesiofacial, maxillary deficiency, low convexity. She has triangled shape of her maxilla. Angle class 1 on molar, but class 3 on canines. Overbite is 0. Some abfractions actually on few teeth, and gingival recessions that I think are her main concern. So, what was the plan? First of all, we were not sure that we can just cover her recessions and leave her teeth like this because they were grinded. And that, for her age, is not stable situation, so we have to think wider. To have orthodontic treatment, we have to do something to extend her maxilla. Then, after orthodontic treatment, after surgical treatment, maybe we will have to close her recessions. And afterwards, some occlusal equilibration, and she's fine, I think. So the simulation of our treatment plan, maxilla, you see this B-shaped maxilla. If we would extrude the maxilla, we will take those teeth out of the bone. So we decided to use SARPA, surgical assisted rapid palatal expansion technique, which is actually not that new technology. The first mentioning dates back 145 years ago. And for this technique, normally we use appliances like this traditionally, but I think that the distractor, the special surgical distractor, is the best option for cases like this, because it lets us control position of the teeth in the bone more accurate, because the support is the bone, not the teeth that can be extruded if one of the fragments will be blocked. So we have some risk to have bone recessions on the roots. This is more safe. So we made that surgery. We performed that surgery. This is the distractor. This is how she looks on different steps of destruction. Destruction protocol was 2 times per day, 0.25 millimeters. We extracted for 12 days, so we wanted to achieve around 6 millimeters of destruction. And afterwards, 2.5 months for stabilization period. After that, back to orthodontic treatment. You can see the approach. 3 cuts, not too big, just from canines to first molar, and one vertical in the central frenulum of maxilla. This is how she looked like on the day 10 after surgery. Actually, in the hospital, she stayed for 24 hours. She spent only 1 night due to general anesthesia. We could not do it in sedation because of the risk of bleeding on maxilla. If we would not have intubation, we would not be able to compensate it, to deal with it. So, this is how we started. This is her picture 2 weeks post-surgical treatment, and this is 5 weeks post-op. when we think that our patients care about what we did, they do some crazy stuff. I would never go there with trauma, with not consolidated fracture, but she feels fine. Actually, she feels more than fine and happy. She enjoyed that diastema that much that he had 5 photo sessions with her sister, actually, and that's how she felt after the surgery like this. She felt more confident, she felt more sexy, even with a metal bar on her palate. In a few months, in 8 months, we could evaluate the result. This is the simulation of what we have done. We can see 2 fragments. We can see that nasal septum stayed attached to the right segment. We can check the position of pterygoid bone to the maxilla, pterygoid processes to maxilla, and we can also check what we achieved from the beginning. This is her the sandy color. It's her previous X-ray before the surgery. So we can see that we achieved some result. And now this is orthodontic stage of treatment. This is 6 months of orthodontic phase, so 2.5 months for stabilization and 6 months of orthodontic treatment. This is her intraoral view. We had to utilize some skeletal anchorage. We use normal skeletal mini plates for osteosynthesis. We can bend them any way we want. So now we can apply them, for example, for intrusion at the left. You can see that this side needs some intrusion. Now she is on this stage. This is what we got before and after. The curve of the occlusal curve. You can see that they really differ. We have no crowding in the frontal area. Once again, superimposition before and after surgery. And actually, if we remember that her main concern was hypersensitivity of teeth, this case was actually about recessions. We can compare a bit and we can presume that we are on the right way because those recessions, they look like they start closing spontaneously. This is after and this is before. We are not yet sure if we need one more surgery for recessions, one more dental perio surgery, but we can see at least the tendency. Again, Yulia, I can't make her look serious now. It took us maybe 50 or 40 pictures to make her look relaxed. Actually, Yulia is Yulia. She is more than happy. We can come back to her changes of the face. If you remember her first pictures, you can check that she looks much sexier now and much more confident after that surgery. So this was cooperation between 2 clinics between two offices, the Dentin and the Porcelain. The orthodontist is Ihor Proshchyn. And this is, I think, the end of those cases. And now I would be happy if I could answer any of your questions.
Igor, thank you for these excellent clinical cases, which were very well presented in my opinion. And I would like to open the discussion of the clinical cases, and I just want to ask the technical support whether we can connect with digital normal. Okay. So first of all, we start the discussion with Professor Ruban. István, you're welcome to start the discussion.
So, Ihor, I'd like to congratulate you for your cases. I really appreciated the amount of planning and execution you did. Can you guys hear me well?
Yes, we can hear you.
Okay, okay. And so the first case, let's go back to the cases. The first case was a complex rehabilitation with implants. And I really liked the way you did the planning and the computer, and then you designed the wax up, and you have designed the future positions of the implants. And then, as it was mentioned, you just did complete a very comprehensive program, which is a great program for learning this. So that we can tell that you have. And I have a few questions. So also you beautifully executed the regenerative procedure in the anterior maxilla. Now, first of all, you extracted some teeth and you left, the molars, okay? And especially the right side, the molar was a little bit of question. And then that molar was extracted. So what was the purpose that initially you left them in? It was for the prosthodontic planning, or what was, again, can you answer this question?
Thank you for your question. We left those two molars temporary because we had to use dentures for temporary rehabilitation, just for reloading, just for releasing pressure on frontal area. So those were temporary retention points for dentures.
So that's what I thought. But then you extracted them. And the membrane was still in place, right? During the membrane was still in place, but you still extracted them, right? Am I correct?
Yeah. Yes.
Okay, so that's what which was not clear to me. And then
at that moment, our dentures were not fitting perfect, so we had to switch to new dentures, which were full dentures. Mm-hmm. That was due to retention of the old dentures.
Okay.
And also, we planned to position implants in the area of those two tilted teeth. And one of those molars, he occupied place of actually 3 teeth. And it was impossible for us to position implant in the right position. So we had to extract it 2 months before we planned to put the implants in, because we could not put implants. They were on the way.
Yeah, I still feel that this was a little bit of a compromise in the treatment plan. So if I was gonna save those 2 teeth, I would have stick to those 2 teeth. I wouldn't have saved, especially the right one. I would have extracted also, as you did. But then, I think if you extracted before, then you would maybe get a little bit of better bone. Now, on the left side, we have seen that when you place the implants, you had some pins in, so you probably needed some regenerative procedure in the left side simultaneously with the implant. Is that correct?
Yes, sure. We also had to do some closed sinus lift procedures. And those membranes, that augmentation was for recontouring, reshaping the ridge,
the bone,
to make it more smooth.
Yeah.
No concavities, to have no concavities. So it's more like plastic.
So honestly, So honestly, I would have liked it more if you would have taken those 2 teeth out. If you would feel that you would go with a complete denture, despite that there is a bone graft. I maybe would have placed somewhere like 1 or 2 temporary implants to try to relieve that denture. But actually, I would have liked to do the regenerative procedure on the upper left also before the implant placement. And because at the end, the sequence didn't seem to me like the way I maybe would have done it. But again, you have done a perfect planning. I really love the planning. You did a great job in the anterior maxillary augmentation, which I'd like to really the bones. The membrane was nicely placed. The membrane of choice was great. Then we didn't see the regenerative procedure with the implant, but I'm sure you did a good job there too. The implant positions were good. So overall, with the final reconstruction, also with the lower jaw, that was, it was a very nice job. Maybe a little slight comment that I have for the lower jaw. The lower jaw, you have done like a circular connective tissue graft around a healing abutment. Am I correct?
Yes. Yes, Istvan.
Yeah. Yeah, okay. And that connective tissue graft
program for sure.
So what was the purpose of that connective tissue graft? You wanted to thicken the tissue, I'm sure. You wanted to have keratinized tissue, or what was the main purpose of that connective tissue graft for that particular implant? Well, that to me seemed to be a little bit over the top.
As far as it's considered that every time we use the blade, we lose some volume of tissues and connective tissues also. So at least we would compensate, and actually it's almost never situations when we have too much tissues around implant. To have more safe surrounding for implants, that was the purpose.
Okay, so basically, the purpose was that you're thickening the tissue to preserve maybe the crestal bone?
For sure, to preserve it from remodeling.
Okay. Do you know any literature maybe about that you have thicker tissue and then you're going to preserve the bone better?
Sure, the most quotable study from Linkevichus from Vilnius that we need at least 2 millimeters. So, but the more we have, the better. It's like celery.
Yes, I was sure you know this. And my comment to this, that when you do this type of the healing abutment and the connective tissue around it, just a thought that it hasn't been examined, but theoretically that connective tissue for the next 2 months will not count until it gets incorporated. So the open healing connective tissue with a healing abutment, a connective tissue, like connective tissue around the healing abutment, might not preserve the crestal bone, because those studies were close connective tissue and then open them and once the connective tissue settles. Once you do an open healing, like a healing abutment, and a circular connective tissue around them, that is not an attachment. That is not thickness for at least 6 weeks until it's going to heal in.
Yes, it's a bit risky, but
just a thought.
I think it's
no, it's not a major issue, but I think it's a principal issue. It's a philosophical issue.
Thank you, Istvan.
Okay, and then so I would say on the second case, the maxillofacial case. I mean, you did a great job. I really liked the planning, and I wouldn't really have much of a comment for that, as that is not my expertise. But it seemed to have that we really enjoy handling the computer, and you do that in the advantage of the patient also. So that's fantastic. That's true for the third case. Okay, that's true for the third case too. Also, with the orthodontic / recession type of case. So with that case, how do you generally approach with patients who have orthodontics and have some recessions? So what is your general thought for for, you had some class 1 and class 2 with the old type of classification, class 1 and class 2 type of recessions. That was for the old type of the Miller classification, right? What you quoted.
Yes, that was
because now
class 2 Miller.
Yeah, because now there is a new classification. But anyway, so Miller class 1 and 2. So how would you approach, let's say a patient has, deep class 2s or this patient and has recession and you're going to do orthodontics?
First of all,
and you're expanding the ridge. You're expanding the ridge.
Consider the position of teeth in the bone. They say that orthodontist can widen the maxilla, but I think it's more about teeth. So we can, before starting changing the curvature, we have to check the position of teeth in the bone. If the position is let us move teeth out, but still stay in the bone, then we can go for recession closure after orthodontic treatment, after we will balance all the contact on teeth, etc. Mostly after orthodontic treatment, but sometimes we really need to protect teeth with connective tissue graft if it's Miller 3, for example. Did I understand your question correctly?
Yeah.
That an answer to your question?
Yeah. So let's say your progression, you may decide that you're going to do the connective tissue graft before. You may decide that you want to plan the connective tissue graft if the case will not improve or it progresses, right? In terms of the recessions progress, which quite often happens when you're expanding, let's say, teeth and there's not much of a buccal bone and there may be a class 2 recession and that progresses. If let's say you're in the middle of the orthodontics treatment and there is a recession, maybe an anterior mandibular class 2 recession that you have not treated with connective tissue graft, but it would progress, then how would you approach that patient? Let's say middle of the orthodontic treatment.
Step back, we have no options. We have to make step back in orthodontic treatment to put tooth back into the bone because we have no chance to close it if it's out of the bone.
Mm-hmm. And potentially then you would maybe plan a connective tissue graft on that tooth?
After the tooth will go back to the bone, it will stay there stabilized for around 2 months, I think. And if the recession is not covered spontaneously, then we need surgery for coverage.
Okay. All right. So, yeah, I wanted to be objective. And, I personally, we have a personal connection. I really like you, but I still wanted to be objective. And I think I was. I hope you don't feel that I was too strict. These were my questions. I think you answered them very well. And again, I would like to congratulate you. You have done a great job. I think you deserve to apply to any positions, to any clinics, worldwide. Okay, congratulations. Good job.
Thank you, Ihor. It means a lot to me, and thank you for your participating in this event. It's something new. Nobody understood the format of this, but I thank you for trusting us and believing in this. So thank you for chance and for your work.
Take care.
Thank you very much.
Take care. Thanks.
Thank you. Thank you, István, from my side as well for your valuable feedbacks and all those comments, and it was really a great honor for us to have you here. Thank you very much.
Thank you, Miroslav. Thanks.
Thank you. So can we move to the next expert? Okay. Now we would like to hear the feedbacks and opinions and first of all questions, of course, from Dr. Sasha Jovanovic. So please welcome Dr. Sasha Jovanovic, and I give you the word.
Hello. Can you see me and can you hear me in Kiev?
Yes, Sasha, and we can envy you with your relaxing surrounding. Actually, I envy you.
Well, I was sitting in a very serious position, but I had to move because
No, it's great.
my
It's perfect.
good. So Ihor, like first of all, I would like to just acknowledge the amount of work that you've done, because I've seen you sweat and prepare for like multiple days and probably multiple weeks, and so I know how it feels, and I know that you did something very unique. But you did really well. You presented well. The case presentation was well organized. Obviously, you had technology behind you, which made it possible for Dr. Urban to be present, for me to be present. I'm actually traveling in Europe right now, so I'm not in California, and we were still able to see everything perfectly. So I'm happy to see you succeed in what we were trying to do this whole week. Good job.
Thank you, Sasha.
Now, now that I've been nice, now let me be a little bit more strict. So the case one, you had already Dr. Urban give some comments there. So like, I think I don't want to duplicate those, because obviously Dr. Urban and myself, we have a big interest in bone and soft tissue. But let me try to take the discussion a little bit different. You basically had an upper and lower jaw in a patient who was relatively healthy with a failing dentition. And I would like to know from you, with all your diagnostic skills and everything, have you thought about any other treatment plan for this patient, which could possibly be a little bit less invasive, have less implants, and maybe also have less grafting needed, that could be of interest for this patient and also have a positive result?
I think that we had an option for mandible to use maybe 2 more implants less, to use, for example, all on 4 or all on 6 protocol. But we decided to leave 2 teeth. We left 2 of his own teeth to try to leave his coordination, to have his proprioception, to keep his proprioception for better coordination of mandible, to have any information for the brain to work. I think it's worth it because we managed to do it in 2 stages. As for maxilla, it appears to be more complicated for me. We could maybe use only distal areas for implant placement, but and leave frontal area as a bridge. For example, from tooth 5 to tooth 4, opposite side. But the residual bone was too soft. It was 7 millimeters high. If you remember, in the area of sinus lifts. If you remember, we had to use, I did not stop on that too much, but we applied closed sinus lift procedures for all distal implants on maxilla. And we thought it would be a bit risky. Also, from the point of view of phonetics, for his frontal area, that irregular shape of the crest, I don't think that would be the best idea. I think we would have to come back to restoring the shape, the contour of frontal area, to let phonetics, to keep the phonetics. And this patient, he is public person, and for him communicating is really important. So that was our choice. Maybe, but
yes,
also
so I
risky.
I think this is the answer is good because I feel that you have thought about it. For me, it's just like it's an important thing for us surgeons, which of course, you're applying for this job position and this diploma. It's important to always go and have an open mind towards also more less invasive procedures. And of course, you did a very good conventional treatment plan with bone grafting and multiple implants and full reconstruction all the way to the second molar. But we have to stay open-minded. Like there's a lot of patients nowadays who want less surgery, they want less grafting, they want less implants, they want faster, immediate temporization. So we have to be open-minded that there's other solutions, like you mentioned, all-on-4, all-on-6, even zygomatic implants, which may be in the hands of a skilled surgeon and in the hands of a skilled prosthodontic team can give the patients a very fast and still very solid treatment plan. So I would just like to see in this differential treatment plan a good discussion with the patient, a good treatment planning, so you bring that in too, because if the patient has the time and the patient has the budget and it's healthy enough, for me the treatment you did is beautiful. But I see a lot of patients who don't have the time, I see a lot of patients who don't have the budget, and then other types of treatment plans could be very beneficial for patients. So I would like you to build that more into your treatment plan, into your clinic. So you have like a traditional way of going, which is beautiful, you did that, but also other treatment plans which are maybe less invasive.
Thank you. I'm sure you are right, zygomas are good options for that case.
Yeah.
One-stage procedure. But
Okay.
I'm not too skilled in that, so I cannot propose this to my patients. I'm not trained good enough for zygomas yet. I have to cover this with maybe the Rodas. Alfonso, I'll go to Spain to Alfonso to get more skilled.
Right. And I think Alfonso is watching you, so he's probably going to text you in a moment and tell you, please, Ihor, come to my island. I'll work with you.
Yeah, I'll come with monkeys. With Jin.
Okay, another comment I have, just kind to go towards the grafting procedure you did, because of course that's my personal interest, the vertical and horizontal grafting you did. I think that was very well done. Because first of all, you got a good vertical height and a good horizontal width. The only thing which you, of course, alluded to is that it was not easy for you to get around the curvature of the anterior maxilla. So try maybe next time when you do this kind of procedure again to utilize a membrane which maybe has a longer PTFE border, so you can stretch the PTFE easier towards the, let's say, nasal cavities, and so you can have a better pinning and a better positioning of these membranes. Because basically now your membrane was too short at the apical extent. So maybe you can have a different grafting result, especially in the apical area where probably there was still some deficiencies after your reconstruction, by just lengthening the PTFE membrane. Do you understand what I mean?
Yeah. Actually now we use two membranes for left and side and right sides of that curved area. How do you think, is that a good option to use two instead of one to avoid bending?
Yeah, I think that you can do that as long as the midline is significant, because if the midline is, you have a nice nasal spine, then that's perfect, because then you can utilize the nasal spine. But if, of course, the middle of the nasal spine is also deficient, then that can be harder. But I've done that many times, to use one membrane on the left side, one on the right side. It works beautiful.
Thank you. Thank you for this advice. It was really challenging.
Okay. Yeah, but the most challenging part, of course, is with having a denture as a temporary, is to keep these membranes submerged with using a denture. So I personally had no problem with keeping those molars, because any type of tooth positioning can help you to temporize and keep the denture pressure from the ridge. So I like to use some type of, when I do fully edentulous ridges with GBR, I really like to keep teeth or type of temporary implants, so it takes the pressure off the ridge.
Thank you. Thank you. That was the idea. We thought the same. And I had really good prosthodontist. He was sure he will keep my augmentation site safe. So thank him. If Taras is watching, thank you, Taras.
Good. So we discussed the first case, so I'm happy with that. I'm happy with the prosthetic result. I'm happy with the pre-prosthetic planning. I'm happy with the surgery. And we discussed the alternative plan. So now case 2, I have to say it's beautiful. I mean, no further comment. I'm not a specialist in that area. But if I see a result like that, that has a positive effect on the patient and well managed, so I have no comments on the second case. That looks really stable and good to me with a good result.
Thank you. Thank you.
Okay, then case number 3. Also here, of course, it's a little bit difficult for me to make an expert opinion on this. The only part of this particular procedure that I have interest in and that I have expertise in is of course, the gingival aspect of these recessions on the patient. And of course, when you do an extensive plan like this, has it been part of your thinking, or would you ever do in patients like this soft tissue augmentation on these small recessions prior to do a surgical intervention, which is orthognathic, the way you did it?
I don't think that in this case we will use any more surgical techniques. But yes, for sure I would use it maybe in class 3, Miller class 3 cases, maybe class 2 bordering class 3, but before. But in class 1, class 2, I would like to wait till to see the tendency of orthodontic treatment, to see if we can improve the position of teeth by changing only torque. If we need extending teeth, I think then I would for sure apply, for sure, to make it safer.
Yeah, I would just want to comment here, and that's of course I think a very important part of gingival recessions is number 1 is to prevent any further let's say advance of this recession, and really think very, very deeply with the patient and with the team. Is it necessary to do possibly gingival augmentations before this advanced procedure? And I agree, if it's small, it's probably not necessary, but you never know what happens with these teeth and with the movements. So I still have sometimes the inclination to do protective soft tissue augmentations, which is minimally invasive if you compare it to the large orthognathic surgery. So I would think about that.
Actually, I would do the the bigger, the wider surgery for her to make her case perfect. But that was the compromise she voted for, and it was really, I'm happy that we had patient that understood the idea of this treatment with a complaint that she feels too cold or too sore. So that makes me happy, that she understands that only in this way we can do it predictably. Otherwise, we had to deal with her occlusion because it was not perfect, and while she is young, maybe the compensation is okay, but when she would grow and mature, maybe the compensation mechanism would fail, and then we would face a more severe problem. So I think it's thinking forward kind of idea, and I don't know if you understand what I mean, because I'm a bit too tense.
You're doing fine. Like, just one comment. So do you believe that occlusal equilibration can stop or prevent the gingival recessions, and that you think that with occlusal equilibration you can actually get gingiva to grow back?
There is no, it's not evidence-based, so I can't think anything like this, but she started grinding her teeth, so it will progress. Then we have risk of cracking teeth, of losing teeth in the future, and we can stop it now before it occurs. I am not talking about equilibration of occlusion for coverage of recessions. In this case, I just mean new problems that can occur with this kind of occlusion.
Good. Okay. Good, Ihor. Well, I'm finished. I know you very well. You have completed the guide 1-year training program in implant dentistry with us last year, and I know I'm going to see you very soon in Santa Monica. So I want to congratulate you with the 3 cases.
Olena is here. She can't stand saying hello to you.
Hi, Olenka. You look beautiful. Yes. Hi. And yeah, I look forward to see you guys. And yeah, I think from my standpoint, I would definitely go to support your diploma application. I think you looked at it very rounded, from implants to bone to soft tissue to overall dental aesthetics, to large surgeries, to small surgeries. I'm very happy with this. So, Ihor, from my side, I give you not 1, 2 thumbs up.
Thank you, Sasha.
And look forward to see you soon. And congratulations with your work. And you can enjoy the relax tonight.
Thank you, Sasha. Thank you. It's an honor for me to have you here, first of all. And thank you for your kind words and for being pragmatic with your evaluation of cases. Thank you for your questions. They were really tricky. I had to think a bit before answering. Thank you, Sasha. Really, thank you.
Bye-bye.
In Europe, and come to Ukraine one day, please.
Yeah, I think I have a plan next year. Yeah.
Thank you.
Bye-bye.
Bye.
Bye-bye.
Bye.
Okay, so we thank to Dr. Jovanovic for his opinions, for his evaluation of Igor's work, for his sometimes tough questions, but he was definitely objective, and I think Igor did a great job of defending his cases. So, as far as I know, we have some technical issues. Well, not technical issues. The problem with Tomas Linkevičius. I think he will
Simonas.
I'm sorry, Simonas Gribauskas. Yeah. He will not be able to join us, as far as I know, right?
Yes, he's in bad connection.
Yeah, so he had some problems with connecting with us. So anyway, we'll still have some hope, and we are waiting. But now we would like to invite to the discussion Dr. Ihor Fedyrko. So I'll switch to Ukrainian, perhaps. Ми хочемо зараз продовжити дискусію, і я надаю слово доктору Ігору Федірко.
Дякую, Мирославе. Добрий вечір.
Good evening, Ukraine. Good evening, Hungary. Good morning, America. As far as I understood, Sasha Jovanovic is in Europe. He's in Zurich right now, so probably some stars are shining upon them. Because he's really a star of a field he works in there, and that was I was very grateful to have an expert to be as an expert here. Before the beginning of the presentation, we spoke about that beforehand. And as far as I understood, that this will not be as an exam, because in Ukraine we are really used to exam like in universities, you know. So there's not going to be any tables with the tickets of the questions. So, and for real, the atmosphere which is here today, it really connects us, and everybody was very into the presentation. We listened to it with a great pleasure and an interest, and it was great to have an opinions of a great experts as Istvan Urban and Sasha Jovanovic, and almost all of our opinions are the same regarding the first and the third case. So, and when I reminisce the beginning of your presentation, and as far as I remember, the patient had a visit in your clinic 1 week before his birthday. So my question was, what did you tell him? What did you have to answer him? How would he look like in a week? So at his birthday, and how did you? What did you explain to him that his treatment plan will take like 2 years? I don't actually remember exactly what I told him, and we were really lucky that patient was a person of a high intellect, and he understood everything we told him, so he did not expect something special from us. So the further steps, we dealt with him on the further steps of planning it, and the first planning, if you remember, we made it with the scan and ICOM files. We made it to explain to a patient what are we going to do. So, and when he saw this, when he saw the implants in his bone, when he saw the logic of what are we planning and what are we going to do, so he understood that this was the long-term planning, but he understood that this will bring him the most ideal result. And when he saw his actual teeth, and if I'm not mistaken, his teeth is 16. It was like 16 September, and I told that we're making it to your birthday on 16th of September, but in 2 years. Yeah, it's great that some patients understand that they have to wait for a year and a half or 2 years to achieve a great result, and I think you need to be a great specialist to assure a patient to make this, to get this plan and to stick to it. And this patient is aged 62. Yeah, it's great when the patient understands what his doctor is saying to them. I agree with everything with the augmentation of heart tissues, and I understand that when you have enough of also, I agree, when you have enough of a keratinized tissue, you do not have to over-augment it and to have an extra risk on here. So hypersurgery is very oftenly present with the young doctors. So try not to, you always want to make a good for a patient. So, well, I know the situation in all 100%. So probably you done what you thought was right, and it's great that the results were great. So I can congratulate you with that. The next patient and two previous experts, they were not commenting on it because that was not their field of expertise. And with me, it's one of my key fields of work. This is surgical dental traumatology, the traumatology in dentistry. So I have a couple of questions regarding the second case. So in your previous presentation, you told that there was a fracture in an area of a right mental foramen, and that was a fair connection of fragments, and that you observed the regeneration of these fields. So the question is, why did you still use these 2-minute plates? And why did they was so why they were used is because we did not plan the future splinting of a patient. The patient was not splinted. He only had elastics only for 3 weeks, which were guided the lower jaw to close properly. And in this case, there was a high risk that only like this he would feel himself safe and he will be able to eat. So probably this was kind of a over surgery, but that gives us a more confidence and stability in a future prognosis, in my opinion. They were positioned in a high, too high, because not to risk the damage of a nerve. And with this position, we were pretty safe in that area, and I think we were safe enough in the zone where we made that. And but at the same time, they were low enough to prevent the future infection which could get there. But we also did not want to be low enough to damage the nerve. So we kind of tried to find the golden middle to place this titanium plate. So that's why that was our opinion. Well, I disagree a little bit with this because in these cases you need to visualize the where the nerve exactly, and you need to place the plate a little bit lower. So I would do it differently. Yeah, I agree that the trauma there was pretty harsh, pretty severe, and they traumatized the fractured ramus in there on the left side. I guess the mini plates. I think in the case like that, you should take a reconstructive plate or a flat plate. You should place differently, because with a fracture with many components like that, well, it was not that correctly, because you need to fixate it much harder. Because sometimes when patient opens his mouth with a fixation like that, he may face another complications, and he may not be able to open his mouth on fourth or fifth day after surgery. And also, I didn't see an X-rays after fourth or fifth month after surgery. So, and that would be interesting to see. To check if there are any movement of the fragments. Igor, I think they will be in 4 months, because right now he is in the second month after the surgery, so we will not see any solidated bone in the regions of fractures up to 6 months. But after that, you will definitely see them. It will be on your table. Okay, thank you very much, and to end my speech, I would like to say that the pretender who is defending today the competence in the fields of surgery, he shows a very high level of skills of what he's doing, and the practical skills of what he has shown. It demonstrates that he knows an in-depth knowledge of every field he's working in. So it is not superficial, but he's doing it like very in-depth and very thorough, and that he can do a very complex surgery. So your development is very fast. And of course, in dentistry, there are a lot of things to learn all the time, and everything is changing all the time. and Ihor Proshchyn, he travels really a lot, almost every conference in America and in Europe, and it's everything is due to he works in my clinic only for a quarter of the full-time job, so that's why he has an opportunity to go to a lot of different places besides his just and yes, and surgery is a very and maxillofacial surgery is a very specific specialty in Ukraine because everybody knows that there are no like an official specialty like that in Ukraine. And everybody names what we are doing today differently. Somebody says it's a demonstrative crucifying, and somebody says it's a show. But I think this is the demonstration of a high-level skill, and it demonstrates that everybody can do that, and I think it's very difficult to defend yourself in front of experts like that. And I think for the patient it's very influential as well, because everybody can see that and see the presentation like that, and he can choose Ihor Proshchyn as his own surgeon. And I congratulate you that your patients are fine, safe, and they can smile, and somebody even can eat nuts. And also regarding the third case, and we have also Miroslava Dragomirecka, if she would be so kind to make some contents. And I'm ready to that. I was preparing myself for that for a very long time. And I think Miroslava Dragomirecka, I think she can evaluate the third case very thoroughly, and I think that would be very interesting for everybody here presented in the room and everybody who's watching the stream. Okay, thank you very much. Thank you, Igor Volodymyrovich. Thank you very much. Thank you that you found your time to. Thank you very much, Igor, for your evaluation, and first of all, of the maxillofacial part of the presentation of the clinical case which was in the field of maxillofacial field, because the majority of us who's presented today, or those who was watching us online, they are more like dental surgeons, not maxillofacial surgeons. So it was very interesting to hear your comment, and it's great that you invited Miroslava to join our discussion. It's great that we can start the next part of our program, so we right now can start the discussion with everybody who is presented here in this auditorium right now. Yeah, I think he's ready to answer you all. Okay, first of all, I would like to for real congratulate you, Igor, because well, because that is a great courage to show yourself finally. So for me, it's because I remember when you were at your first courses of orthodontic courses. I remember what you told: I want to be only a surgeon and nothing more than that. And today, you have an opportunity, and there is an opportunity to see you here as a real doctor, a dentist who has fulfilled his dream, because you're showing only your true surgical love and mastering. I will not speak really for us. The presentation, I don't know the idea of why it is needed for us, but for me, personally, for me, you are a surgeon today who's presenting his cases. And as a kind of a expert, and because we didn't have a connection with Simonas Grybauskas, but we have a specialists here from this area, like Larissa and Artem Dubnov. So first of all, regarding the third case, well, just third case, because first and second, I cannot be an expert in the first and the second case. The only thing I can only ask is just professionally for the first case is the periodontitis such as severe like that, is there any risk of is there any risks in the future for the peri-implantitis? And because as far as I'm concerned, the risks are high, and so how do you deal with them? Yes, indeed, there is a lot of risks in that. First of all, it's diabetes. The second is so we have an influence on the blood supply, the small vessels, and also also the obesity, which influences the metabolism as well. Also, that the part of the implants are in the new bone, which are, it's not that good prognosed as a known bone because it has not been before there. So that's why we made a really long pauses between each step to lower the risk, and also all of this takes a high and also the professional hygiene in these cases. It's like we made it 2 or 3 months. So as far as I'm concerned, that when you have a severe periodontitis like that in future, well, maybe not 100%, but a very high risk of peri-implantitis here. So the patient goes to a very high amount of surgical augmentation. And so do you tell them that in future you can face a peri-implantitis? Do you tell it to a patient? And it's really interesting for me, because we know that there are a risk. So do you tell it to a patient? Yes, of course, we say everything to our patient about every risk we know so far. And also, I think it's very important not to leave this patient alone with the issues he may face in the future. So I'm pretty sure that once anything happens with this patient, if he face any problem which needs to be solved, we will never kind of abandon him, and we will solve the reaction. But the prognosis is always like 50%. Okay, so the third case, not to delay it. I can explain. In orthodontic surgery, it is very important is the planning of the treatment of a patient. The patient has come with a hypersensitivity, so so you just jump to orthodontic surgery, and you kind of made her facial look worse. Your surgery, especially, that was great. That was fantastic. Yeah, so you made a very fantastic surgery, but the planning of the orthodontic treatment and the planning of this treatment, I would disagree. It's not you personally, it's mainly orthodontist, I think. But so will you plan anything with a lower jaw, anything? Because right now you have a facial worsening of the situation because you have a rotation of a lower jaw. So I have a question: what was the plan of what was the plan of the orthodontic? Why did you intrude the premolars on upper teeth? Because you worsen the rotation of a lower jaw. So that's why my question. I have more questions to orthodontist, not to a surgeon. But in orthodontic Surgery, it's very important that the surgeon sees something, but the one who rules the process is orthodontist. So again, the question to the planning: what will be next? What's your next step? What kind of plan does orthodontist have in her mind? I mean, what you did, the execution of what you performed, it's great, fantastic, but the planning is. I have a lot of questions. It's basically the questions to how will you finish this orthodontically, because intrusion in premolars, what you did, I do not understand it completely. I mean, what did you plan with it? What you, I do not understand it with the planning of facial aesthetics and with the rotation of lower jaw. If you may, this patient, he's not like, he's not only multidisciplinary, he is also a referral from other clinics. So unfortunately, I do not have access to the whole clinic, and of course, this is a partially of my mistake. I may so probably my assumption that there's an intrusion in premolars. Maybe I made a mistake. Yeah, because the presentation I did here, I only made it from my point of view. Maybe I do not have all the information from my colleagues who run this case, so I do not have all the aspect. I do not know all the aspects of the orthodontic treatment planning, but I'm pretty sure that the final facial aesthetic in this patient will be perfect, because she's right now in a in a very anesthetic part of the treatment, because right now he's a third class, and he's got a reverse bite, and this is this is what I this is was what I wanted, because I wanted to keep the incisor papilla. But what are you doing that if you're not planning any more surgeon here? That was very essential, because when you because in that fast in a fast surgery like that, you may face with when you lose the interdental papilla in there. So now when we artificially achieved what we wanted, and we are artificially trying to achieve a place for interdental papilla between the central incisors, and this is in fact the middle step, and in future we will compensate it, but I just want you to pay attention that I know that for you it's very important that the papilla, but there's also an orthodontic flattening. The You have a very wide occlusal curve, but it's very flat. Yeah, but it's temporary. We will make a step back in the future. What we have right now, we have. This is because I asked it to be fulfilled, because interdental papilla is very important. Okay, our discussion is has shown how the clinical thinking can always be in a discussion, and it was very professional, and thank you, Igor, and bravo. Thank you very much for your comments, and your opinion is very important for me. I knew you will be here present today, so I was preparing myself very much. Thank you, Miroslava, very much. Colleagues, if anyone else wants to join the discussion. Hello, Zhenya. Yeah, you promised to be here. I'll step forward to be. Okay. Okay. My name is Evgeny Zakharenko. Okay, so there was two experts, uh, foreign experts, and two experts of ours. And so right now I'm asking Yaroslav, why do you need four surgeons? Give this one to me. Okay, so it's not a joke. It's not a joke that I am inviting you to my team. I'm hearing how my salary is rising. I can criticize, nevertheless. I worked in the in the maxillofacial hospital before. The plates were perfect. Yeah. Sometimes very fast terms can lead to a very great complication. So I don't know how in your department, but on Padvysotsko, Valery Valeryevich will not let us lie, but there's a lot of osteomyelitis, and sometimes patients just eat a lot and after a great surgeries. So I think you just you should not follow what patients want, and you should be more strict with them. So you should. What I can critique today is there was a couple of questions regarding the first case, and this is one of my favorite cases today, what Igor showed today, and you already answered the questions like that. But for now, how would you in terms reduce the terms of this case to achieve the same result? And what do you plan for the final prosthetic reconstruction? A bar? So if it's a bar, then why would you do that for 2 years? You can make it in 2 days. On zygoma, you means? No, not on zygoma. The deficiency of bone. So right now, Nobel does a very great implants. Because why I ask today? Because a year and a half ago I made the same. Kind of you kind of enjoy it, but then you wait with the patient the same way. But today, for example, V2V. V2V concept Nobel does, like Enrico Ingliardi suggests, it gives an opportunity, even without, even flapless, you can load 6 implants immediately and you have no peri-implantitis and nothing like that. But I would suggest it to you, maybe 2 years ago, what you did, it was, or 3-4 years ago, I made it the same as you did today. But why I ask today? Because every year we grow up and everything is changing. So maybe today, would you approach the treatment of this patient the same way as 2 years ago? We have a patient, one patient with zygoma, and I think this is the zone I need to be trained in. Me personally, I'm not completely, it's not like you go on one course or visit one operation. I need to fulfill the complete program regarding this. So right now, I know that if you find a correct spot to anchorage an implant, I know that you can reduce the terms and reduce the risks of implantation. So yes, I agree of what you're saying. And And yes, in the very end, we want to restore of what was natural at the very beginning. We cannot like invent something new. We cannot suture the third hand. So the idea is not to make it ideal. It's just to restore as much as possible of what was naturally performed. And but patient pays for that, for the operation he is undergoing. But also, in my opinion, that for and our patient is not that young. It's like he's 62. Yeah, that's right. That's the patient for zygoma. But probably in this case, I will not play zygoma because zygoma is probably the last stage I would suggest. But but in a protocol and generally, zygoma is like for patients 60 plus. Yeah, I understand that we can take a look at the CT. Yeah, we can take a look at this. We can find a spot for zygoma or for whatever you want. But for the future construction, if it's a bar, then there's no need to extend it like that. Of course, if you plan if you plan it like screw retained construction, like fixed construction, then you can place that much of an implant to divide it in the segments. But you understand, but I cannot. I'm not the one who takes an absolute opinion regarding the final result. I'm only a surgeon. I'm only a surgery. So the final word for the reconstruction is always after the prosthodontist.
Це остання
But we never want to complicate things. So we do not want to complicate. I didn't want to make it like something like extra, like zygoma implant, So we wanted to make it in a more natural way, kind of restore the teeth in a way that they were restored. I mean, in an implant in the position of a teeth. And yeah, but with the zygoma you can like make it zygoma and soft tissue augmentation. You can make this in 2 visits. Yeah, I agree, but also the way we did it today, I can make it today with 2+ visits. And right now we are starting to change the surgical intervention down to 2. And I think in October I will have an opportunity be maxillarily closed in two surgical interventions. And I promise you I will demonstrate this case in this way or another. Yeah, I agree with Evgeny that there are methods of less invasive surgical intervention, but I also have a question to Eugene. How would you place implants in the frontal area? How would you place implants in there with enough amount of bone? As far as I understood that the deficiency of bone, we would compensate with soft tissue augmentation. So if your methods you have suggested today, how does they have a long-term results? I'm not saying I defend Igor regarding his the way that he restored it, because I have similar cases. So and yes, there are certain questions in that area. But my question is that how can you achieve? I think that if you did not augment in the frontal area, you will not achieve that great results. Well, if we start for the very end. So first you plan the bar. When you plan the bar, then you can plan everything else. That's the surgery exactly. So if you plan a flapless. So here, for example, if you do it flapless, you will probably not have any complications in the future because you do not damage soft tissues. In my opinion, there's a very powerful expert Enrique Igliardi in Spain, and he has a learned term results. So my results are for like 3 years. It's not long, but even if I place implant, for example, like in the socket, and I didn't have a resorption because I have subcrestal position of an implant, and then I restore it on the bar, and I think I like me personally, I found that the less augmentation I do, the better results I achieve. So once again, it's a question of long-term results. So we do not yet know if just the soft tissue augmentation compensation of a lack of a bone can in future, like for example, after 10 years of functioning, completely work the same way as a bone. Thank you very much. Yeah, I'm very proud, honestly, that working in a stationary for 10 years, I have not yet saw a maxillofacial surgeon who does a dental surgery that accurate. So I'm I'm very proud to see a maxillofacial surgeon like Igor who works the dental surgery at the same level to the same extent. So honestly, that's very rare to face a person who does both direction and works in both field with the same precision and at the same level. And I wish you the very best. Okay, colleagues, I think we can. Okay, I think we have a time for a couple more questions. Valery, thank you. I will allow myself to stand up here because I have a couple of questions. Thank you, Evgeny Alexandrovich. Well, first of all, thank you very much for the invitation. Because for real, that was a very interesting format, and that was very interesting and very dangerous because there is a job and it's done, and there is an open access to the information, and also there is a patient who listens to it. So it's very psychologically difficult to listen because patient can hear that they hear someone other specialist's opinion that they would do differently or something is not right. So the next question is regarding the Evgeny today said, and he that the best augmentation is the augmentation you have not performed. So in your opinion, when the patient after 2 years he decides to have a bar, that's not that great, because first of all, as a person of a team and who does a certain who does a certain stages of the multidisciplinary work, so you should know what a prosthodontist plan to do. So, and I agree with Eugene here and with experts who ask that the patient has a diabetes, and so he does a problem, and you still perform a very risky operation, a very huge augmentation in frontal area. That's a great risk. So, you had a very great computed aided uh, modeling, and you could see that you could just place 4 implants in the backs and have the same construction of the on the same bar, but and also you could, for example, extract the teeth in the back from the very beginning, place there an implants, and like an all-in-4 concept, making an immediate load in there. It's like more. It's not a question. It's more like a discussion, because what you did is perfect. It was done great. But what is what is because, like, for example, if you're speaking about orthodontics, you can judge the result on on photos, but in surgery, yeah, you can you can see the approach as well. Because for me, for example, when I look how the surgeon works, I always look how does he cut, how does he surgery, because I try to find a logic beside, because your photos are great. Yeah, it's done. It's great. It's great. No, Igor, honestly, you've done a great job. Yeah, and it's great you agreed to do that. It's great, yeah, to hear an expert thoughts and then understand that it's very stressful, because you stood up here, you have done it, and thank you, Yaroslav Vladimirovich, that he has done it, because that's a challenge. Because I cannot evaluate the result of what you have done, because I don't know what a patient did want, and I don't know what you were speaking with him about, and I don't know what the prosthodontist was speaking about him. So to me personally, as a surgeon, the thing I pay attention to is your manual skills to understand if something was done right or not. But because that the things which can show, because in surgery it's very impossible to see your approach, your philosophy of what you do, because on photos you can only judge before and after. So in first case, in my opinion, the same as Istvan and Sasha Jovanovic asked, so that you could have done it in a less traumatizing way. So understanding the final reconstruction in prosto is very crucial. Regarding the second case, I agree that these two plates in the mental area, they do not spread the loading because they are too high, and they're mechanically they do not hold the fragments, and it will. So these plates intraoral perfectly, but you should position that more to the margin of of the mandible.
Думку, є певна фізіологія, біологія, яку треба враховувати. І дуже багато пластинок, навіть міні-плейт, але кортикальна, там, де був перелом, це теж ризики. Тобто, знов-таки, питання в тому, що вам це вдалося і це шикарно. Але не факт, що це буде так само далі. Тобто, коли ви працюєте, знов-таки, ви маєте планувати, є шикарна програма, ви робите стереолітографічні моделі, ви можете ці пластинки зробити заздалегідь. У вас є такі технічні можливості. І спланувати, де ви їх будете фіксувати. Тобто це знов-таки в плані рекомендацій. Ок. Ну і по-третьому, по ортогнатії, мені дійсно дуже сподобався виступ Мирослави Стефанівни стосовно того, що...
So, and regarding the regarding the recessions on the third case, you as a surgeon, you need to understand all of these stages, and you need to understand what's going to be at the very end. So it doesn't matter if the patient asks something from orthodontist or from you. You need to tell the same things. Only in this way you can make sure that the patient understands of what are you speaking about with him, and so what are you doing with him. Right now on the third case is just the middle stage of the orthodontic treatment, and I think it's very difficult to judge it. So I'm pretty sure that this case will be completed aesthetically and functionally, at a very high level. So right now we are in the middle. We are on the way, and this is not the final result. It's not surgery when you've done, and after 2 weeks, if you succeeded or not. And in orthodontics, it's not like that. So it's only a middle step. So I think we just should wait and to see. Regarding the question regarding the cortical or bicortical fixation of the pins, there was a lot of fragments, and we were a little bit limited in time, because it was a patient who was from another country, so he just stepped in, and we made a CBCT, and then we ordered a lot of instruments, those we need, and 150 extra in a case we need something extra. So then we made a planning with the models, and there is time, and we were already at 11th day after the trauma. So it wasn't kind of a guided surgery. It was more of a classical approach. So thank you very much for your comments regarding the methods of fixation of the pins. But for example, for orthodontic interventions, when we use the same plates with the same hardness, it all works, and all the constructions which is there, it's not that stable as we would like it to be. But for today, it is. Everybody knows that this is the way of fixation which is prognosed, and the contemporary protocols which are used in the orthodontic surgery, they do not require the splinting of 2 jaws. And of course, I do want it to be very stable, but the reconstructive plate in that area, it would not solve all of the questions anyway. So anyway, we would need to use the regular 2mm systems, and it would make our surgery more aggressive. We had found the candle in there. So it was intraoral, was an intraoral approach. Only for extraoral, it was only punch. Yeah, I think I agree totally that with an extraoral approach, you could have done that. That's why, Igor, that's why a lot of questions, because we as a surgeons, we don't see the stages of what you're doing, because we can only see before and after. So there are only, that's why there are a lot of questions, why here and there. So in future, if you have anything like that, I would really love to see the operation itself. So thank you very much for invitation and for a great presentation for real, and that you have an ability to demonstrate it. That's respect. Thank you. Valery Valerovich, actually, he is the first surgeon I have ever assisted. He is not probably remember that. Probably for the pretender to relax a little bit. I'm a plastic surgeon, and thank you, Mr. Zablotsky, for invitation. So it's great to see how can you it's great to organize an events like that. So I think all surgeons should do it the same way, and I think this will be in plastic surgery as well. And this is very useful. First of all, this is useful for an owners of the clinic. So this is I'm very grateful for Zablotsky, and I'm very for the event organization, and that was fantastic. I think right now we're heading to the end, and I think Mr. Zablotsky can summarize everything. Yes, so I think he can tell about this idea, because I can tell that the event is successful. Yeah, because probably not everybody knows all the details and issues, but from the very beginning I was sure that it will be successful. Thank you very much, first of all, that you have attended this event. First of all, I would like to thank separately to our experts who are not online already, and probably I can make some consensus. And well, probably we have started this open presentations earlier with UAP, with Miroslav Selenko, and when we had a question how to find a team of dental hygienists, I understood that my competence is not enough to examine them. And then there was the idea to ask Ukrainian Academy for Periodontology for business. You know what an outsourcing is, so we needed an outsourcing. We just asked another organizations who educate specialists for hygiene procedures. For example, me as a As a director of a private clinic, my mission is to treat people, so to aid people. I'm not university, I'm not running any experiments, so I'm only treating person. And I think these first public presentations, which were held with hygienists, first of all, we made it with public. Thank you. Thanks to Oksana Shakera, thanks to Tamara Valinska. So not Tamara or Shakera are not working in Zablotska, but they were the one whose word was the last who will be working in Zablotska. So there was 30 pretenders who made a public exam. So the 70% of the exam was in English, and they were not making it to me. Then the second stage of this exam, we made the same through internet. So examinators was Tamara and Oksana, but the rest could see how how everything was held. So, and there was two grades, yes or no, have you passed it or not. So this is the third stage of the presentation, of the public presentation. And I would say you that Ihor today, he was defending three competence. He was not defending the competence of the planning of orthodontic case, or to use bar or not bar. He was defending. He was defending the competence as for me as the owner of the clinic, if he can or cannot do of what he is doing. So, and nevertheless, everybody has their own opinion. You know why I agree that beside that, without them, without foreign experts, we cannot make an open presentation on LinkedIn. And I know what I expected from them to hear or not to hear. That the way the pretender works is not as the evidence-based medicine goes in the world. So what we have seen today is that there are a huge mass of methods and options of the evidence-based medicine protocols. So I'm pretty sure that I know that these experts would always say that he did not he did something wrong or something like that. So they did not tell it today. They did not tell that Igor made something wrong. They did not tell that he has used any method or protocol which goes across to the evidence-based medicine. Of course, they would do this or that operation in a different way, but they both do it differently. They does the same thing, but they does it differently. And of course, and I think today and tomorrow we will receive comments and the letters of from people who are watching us today, and I know that people are watching us today from Poland, Turkey, Cyprus, in Bulgaria, in Croatia. So this is what we know. And a lot of people are watching us in Ukraine. And of course, we will receive some comments from them. Thank you very much, Miroslava Stepanivna, for your comments, because I was very eager to listen to you. It's a pity we didn't hear Simonas Gribauskas, because I would like to hear from Simonas to make a. So, for example, I need an orthodontist in my clinic. I do not have an expertise to decide if this orthodontist will work in my clinic. So the next will be orthodontists, Miroslava Stefanivna, who will be standing here, and you, and the same experts who they can choose themselves. They can be their students or anyhow, but they have to defend their skills and their minds, but they have to defend it publicly. Because, for example, when I open Facebook, for example, a year ago, when you open Facebook, you see only teachers. For example, a year ago I have graduated and already I'm teaching everybody. And they come and tell I can work, so not to work with people like that. So as Pavlo said, if you want to work with people who are of a high competence, that's why I ask you and foreign experts so to test this pretender. So if the pretender does not comply to these criteria, then he works as a hiring.
А те, що я чув, і для мене було цього цілком достатньо. Я можу сказати, що сьогодні Ігор Прощин публічно.
So I can say that today Ihor Proshchyn is publicly acknowledged as the surgeon with these competencies. That was manly. Yeah, he was very nervous about this. And let anyone else try. Let's do this not only for me. I think
Саме так. І саме так ми будемо публічно говорити про те, що Асоціація пародонтологів сьогодні гарантує за 3, 4, 5 фахівців, які здали публічні екзамени вам. Асоціація ортодонтів гарантує і каже, його можете брати. Мені здається, що всі клініки, які тепер виходять українських, а до нас скоро Західна Європа стане у чергу. Тому що ми точно будемо розуміти, що люди, які виходять на публічні презентації, перше, мають таку сміливість, мають знання, а наскільки їм вдасться захистити свою компетенцію, це все буде видно. Тому дякую всім вам.
So again, thank you very much. I think we will make our conclusions, and I know that not everything is perfect, so you can write about it publicly. What can we change? I'm very grateful, and thank you very much for the time you've spent with us. Can you drink champagne already? Okay, thank you very much, and thank you very much to all of those who are watching us online. Yeah, and let we give him a word right now. Okay, I'm just 2 seconds. I would like to thank everybody who I work with, because it's not only my work. This is a work of the teams I work in, and thank them. Thank you, Larissa Alexandrovna, and it's not an advertisement, but she does have an outstanding operator of software and hardware machine, so he does that everything perfectly. So sometimes all of these simulations, when I expected to be done in 4 or 5 days, they were done by like really fast. Sometimes I was like, we can make everything in 4 years, in 4 hours. Yes. So best regards to So, and thank to every doctor and Alina periodontologist, and to everybody else. I'm a little bit nervous. Yeah, to Yaroslav Volodymyrovich.
Я десь розумів, що якщо включно з вами якісь мати стосунки, крім недільних обідів, це будуть якісь дуже цікаві авантюри.
I knew it from the very beginning that I will have something with you besides the Sunday lunches. So I didn't know what we have achieved with this, but we have achieved something. And thank you very much that you have spent your free time. You spent for your profession, for my profession, and for what are we doing. Thank you, and thank you, and thank to this guy, and to me for what, and to you for your help, for your support, and for everything else. Thank you. And thank you. I know that you are very occupied, and thank you very much for coming. And also, I would like to close today's event, and a couple of words I would like to add from myself. And I know that everything has happened. It's not something new. This is for real. This a normal practice of demonstrating of the competence of this of people all over the world. This is the way you acquired a diploma. I watched it for real in Spain, for example, when a person in university he needs to does the same way. He must do and this works the same way all over the world. For example, I was doing the same way a couple of months ago as a periodontologist, and the format was the same. So I was presenting one of the five clinical cases in front of my colleagues, my teachers, tutors, and experts. And that's a normal practice. And I'm very grateful and I'm grateful to Yaroslav Volodymyrovich that we have an opportunity to have it today in Ukraine. And I think that initiative is going to be supported in the future. I know that it wasn't just for Igor. And I know that Igor is my friend, and I know that he's not the person who's like very eager for that. So, and I know that a specialist he is, and I know that it's not that simple to show what he knows how to do, and not only to have the ability to show it, but to defend it and in front of experts from all over the world and from Ukraine as well, which is not that much easier. And bravo for that, Igor. And I'm pretty sure that the cases like that, the events like that, will be held in future much more. And support this idea, and colleague, let every of us have a courage to stood up and does the same thing. And bravo to everyone. And once again, as the moderator, I invite you to. And also those who are watching us online, we are very grateful for your support. We felt that there was plenty of you. We will see how many of you were there. And we also suggest you to drink a glass of champagne, but in a distant way.